Hi there, this is Dr. Katie Mineta and Mr. Zach Pesha from the National Social Anxiety Center. Today we are interviewing Dr. John Grayson, a leading expert of the treatment of obsessive compulsive disorder and author of one of my favorite clinical books, Freedom from Obsessive Compulsive Disorder. Hi, Dr. Grayson, welcome.
Hi, it'd be good if you call me John.
Oh, great. Thank you, John. So first, we thought we'd start off with...
Can I call you John too?
All right.
All right, you'll allow it. Thanks.
He'll allow it. First, we'd like to ask you a little bit about your history and how you came to have an interest in treating OCD and anxiety disorders, and maybe a little bit about what led you to write a book.
Well, I'm where I am purely by accident and uncontrollable events. Because when I was applying to graduate schools, I had my list of good schools, and I was looking for safeties. And so one of the safeties I applied to was University of Iowa, and it wasn't until I got in I discovered I had accidentally applied to a good school. So I would not have applied to the University of Iowa if I knew it was a good school. So I ended up getting into Iowa, and
We are a hidden gem here.
it was. I could go on
True
about
story.
Iowa, but I'll save that for later.
Yeah.
On my internship, which was at Brown, we got to kind of pick our rotations, and the one rotation I did not want was on the alcohol rotation, and I got stuck with that one. And on that rotation, I learned all the things that really are the basis of the goal support groups I run for OCD, and a lot of my early reputation was based on those groups. Finally, when it came time to apply for a job, we were up in Rhode Island, and my wife and I, we wanted to stay in the Northeast. I really didn't want to return home to Philadelphia. It's like I don't really want to apply there. Like the only decent job I could get was working in Philadelphia under Edna Foa on her first OCD grant.
Oh, wow.
So there are 3 times in my life where if I could have had control, I would have made the decision that does not put me where I am today. And I like to think it would have been a good alternative life, but I'm really liking this one. So, so I'm here by accident. In some sense, I think falling in with OCD was kind of natural, even though I didn't realize it, because, I used to walk around high school thinking that nothing really exists and we make it all up. I was already, and I had a teacher who used to respond to everything with more or less. And I remember him talking about Greek mythology and talking about a character committing suicide, more or less. I aggravated people for the next 4 years, saying more or less at the end of every sentence. But so I was kind of set up to live an uncertain life, or where that was the core of it.
So like right now, my wife is pregnant, more or less.
Yes, exactly.
Got it.
More or less.
If you can commit suicide, more or less, I think pregnancy, more or less, is for sure. So I think in her 9th month, she won't feel that way.
Got it.
I wrote an article, Zach, I'm not sure if you ever read it, but I wrote an article for the National Social Anxiety Center blog that was all about, it was all about cogito ergo sum, right? I think, therefore I am. And that's Descartes. And it was on his journey to figure out what he could truly think was real. And at the end of the day, the only thing he could say was real was that he existed.
And
everything else could be a myth, right?
Yeah, and what I'd be sure is, like, as near as I can tell, I exist.
That's right. As near as I can tell. That would have been better put, I think.
Yeah.
So could you describe your approach to the treatment of OCD?
It starts simple and then gets complex very quickly. So obvious, well, maybe not obvious, but exposure response prevention, ERP, is considered the gold standard of treatment. And certainly, from that original time with Edna, there are ways in which treatment has not changed. I currently argue that ERP is not the gold standard. that ERP, and it's not the gold standard because it's missing the gold. Yeah, so if we were going to think about it, I wouldn't write ERP. I'd write treatment should be ERP plus gold. That's a little unwieldy. So do either of you happen to know the chemical symbol for gold?
I don't.
No.
AU. So I would write treatment is ERP plus AU. And
I'm writing
AU
it
would
down.
also stand for accepting uncertainty. So I'm glad you enjoyed that, Zach. It's really unwieldy to get there, but I love it.
Yeah.
But, you know, because so I do think that at the core of almost all OCD issues is that the individual has an intolerance of uncertainty. You know, they're trying to be 100% certain in whatever they are, is trying to do, whether it's, I want to be perfectly clean, I want to know that I'm not going to kill anybody, I want to know I'm not evil, whatever it is, they're trying to be 100% certain. Research has shown us that the only people who are certain are stupid. Think QAnon and Trump supporters.
Oh, no.
So, so try to do the impossible is really hard. So what I find is a major problem in OCD treatment. Well, I mean, we have two. One is all the people who ignore the recommendations of the American Psychiatric Association, American Psychological Association, the International OCD Foundation, and virtually every OCD expert to do ERP. So that's a little frightening. You know, we know that it's easier to treat OCD than to change the behavior of mental health professionals.
Yes,
You know, which is funny.
That's a
except for the
really
people,
good way to put it. Yeah.
it
yeah,
really
which is
is.
funny, except for all the people who are suffering.
Mhm.
That
Right.
aside, then we just have a lot of ERP that's not well done. And one of the major mistakes that I see in treatment is people who start treatment without making sure the person has agreed to treatment. So in terms of accepting uncertainty, before I'm going to start treatment, I need to establish that the person wants to learn to accept uncertainty. Critical verb, learn. Nobody gets to decide to accept uncertainty. You can decide, though, I want to learn to do it. You know, so the beginning part of treatment is, you know, what are all the different things, and we can get into it if you like, because I think it does cross many disorders, that I'm going to have to do to help somebody learn to accept uncertainty. You know, we had a guy come, a therapist brought a guy to me for treatment. His fear was he really hated the fact that he or his family could die at any time. And she was doing the seemingly correct ERP with him. You know, they were imagining his family dying and all this horrible stuff, and he wasn't getting better. So, you know, he meets with me and her, and I say, well, do you accept the goal of treatment? And we go around a little bit because I was trying to make him guess until he was finally aggravated enough to go like, well, what is the goal of treatment? The goal of treatment is for you to be happy in a world where you or your family can die at any time. I don't want that. I said, okay, tell me the alternative. And he laughed. And I said, this is great. Now we know why you weren't getting better. Because although you were doing the right form of treatment, you had some other goal in mind. So it's not like you've got the super horrible case of OCD that's untreatable, or there's something else wrong with you that makes you untreatable. You simply had the wrong goal.
Yeah.
And then he did something really sad. He refused to take that goal.
Mhm.
He's already admitted that there is no other world, but he doesn't want to learn to accept that and be happy in that world. So he went back with his therapist, and I don't know what happened.
Wow.
With my clients, I will, you know, sometimes people are on board from the first session. I mean, not that it's easy, it's painful. Other people, I have one fellow, it took us 3 months, you know, to get to that point. But if they don't have that goal, then I'm wasting my time. I'm wasting their time. And I've seen so many people come to me where they've had ERP, but they never accepted that goal. So, you know, the trick is, how do I get them to, you know, I think everybody accepts on the face, okay, there's no way to be certain. So I want to live with uncertainty, but we have, you know, but what does it mean to live with uncertainty?
They accept it like intellectually though, like,
Exactly.
yeah, it's an intellectual exercise. It's not, it's experiential.
Yeah,
You're
like
only exactly right. And so to live with uncertainty is to say, I'm going to be willing to allow the worst thing to happen. And if the worst happens, I will try to find a way to cope with it positively. And until I get to that, I can't really do treatment. And I think there are some secrets in this area that people ignore that are really obvious. In our Western culture, we say acceptance, and everybody kind of gets the Zen Buddha, like I'm really happy and everything. And you really need to start with the realistic description of acceptance. So basically, acceptance sucks. Because acceptance means I'm going to be willing to live what feels to me the second best life. And the opposite of acceptance, denial, is really common. And many times if I ask psychologists what is denial, it's kind of cool. They
over in
can't tell me.
Egypt.
Well, they can't. But they can't tell me what denial is. It's kind of like, well, they're denying reality. But let's face it. If I have somebody who comes to me who's lost a loved one, and I say you're in denial, they're like, "Screw you! What do you mean I'm in denial? I'm miserable because they're dead." So denial is not like they don't know they're dead. So I think, because I did spend like years trying to figure out like what could be an operational definition for this. And what I ended up coming up to was denial takes place whenever we compare reality to a fantasy. So in the statement of the loss of a loved one, the statement of denial is life would be better if my loved one were still here. It's a fantasy. And the thing is that if I compare life to a fantasy always wins because I don't put any crap in the fantasy. Unfortunately, the fantasy will never happen. And so how do I help a person move from this denial? And there are a few reasons, core reasons to move from denial. One, whatever it is never happening. Two, in what way is holding on to denial messing up my life and messing up the lives of my family? But I still have to go to that third one. What do I lose by giving into, by accepting it? So again, in death, the statement of denial does sound better in a way. Life would be better if my loved one's here, and this, acceptance is they're gone. It's really stark. But moving from denial to acceptance, it doesn't mean I'm not going to cry about the loved one being gone. It doesn't mean I'm not going to miss them. It does mean I reach a point in time where I'm no longer comparing what I'm doing right now, every moment, to what it would be if only they were here. And statements of denial are really subtle. In the beginning of the pandemic, everybody's going like, well, this can't last all summer. I can't take it. That's a denial statement. Because it's like, really? And 3 years later, it's kind of obvious, like, really? Well, you did, you survived, but it's a denial statement. It's like, I don't want this, as if you had a choice. Early in the pandemic, my wife Kathy and I were taking a walk, that pandemic walk, you're never really going outside, and now you're going outside and like you're staring at everybody to make sure like you don't breathe or die, and Kathy says to me, God, this would be such a great day if all this wasn't happening. And I said to her, you're wrong, Kathy, which should tell everybody being married to a psychologist is not necessarily fun. It is a great day. We're here together. We're going to spend the day together. It's a beautiful sunny temperatures, and sunny day, temperature is great. The truth is, it's a great day to be together, and it's horrible that all this is happening. Mindfulness and acceptance is the state of being and, not or. Both are true.
Yeah.
I had a couple who had, I actually treated this child. She was 17, and her parents one day were driving out with all of them to the desert outside of LA to buy a vacation home when a car rammed their car. drunk driver on her third DUI, and it killed my 17-year-old patient and her brother.
Mm.
And I saw the parents for treatment. They were amazing. They coped incredibly well. But when you talk about losing kids, coping well, the only good thing about it is better than not coping. They reached, they actually bought the vacation home they were going to buy that day, which most people are going like, what? But it made them feel closer to the kids. They did not push that away. But this one day when they were far along, and it was going to be a meteor storm shower that night. So they were like going out to watch this meteor shower. They go out at midnight, lay down on their backs, and immediately start crying because these two kids, they were actually at 17 and 14 who would have been out there with their parents enjoying it. And so I asked them, I said, so was it a pretty meteor shower? And the dad goes, yeah. Are you sorry you saw it? No. I said, the truth is, it was a beautiful meteor shower and it's horrible that your kids were murdered. He has kind of a dark sense of humor and said, but I thought we'd get a few moments of respite, but we agreed that wasn't going to happen. So acceptance sucks, but not as bad as the alternative. And so it's a state of like, both these things are true, not or. So in starting with acceptance of uncertainty, helping the person agree like, okay, this is what I want to learn how to do. Sometimes people say, well, I don't know how to do that. And, the answer is really simple. You and I are both hoping that I'm good for something. But that allows us then to start doing the scary work, and I think I don't think, treatment's not fun. Like I think treatment and staying sick are kind of similar. The only difference is one is an end of rituals and the other is endless rituals. So in terms of, I guess, my approach to treatment, I think the first part is this general idea of, everything is uncertain. And can I do one more clinical tale?
Absolutely.
Okay. Obviously, just in case it's not obvious from people who let me talk about them. I was seeing this woman who was doing really pretty well in treatment. I mean, she was really doing a lot of stuff, but she said to me one day, despite the fact she's doing well, I said, I always feel like I could control things, like since I was 4, and she meant since I was 4. And like if I got cancer and they told me it's not curable, I'd find a cure. Inside, this was kind of a challenge now. So I go like, well, how would you do that? So I'd look on the internet. And I said, okay, let me get this straight. You're the kind of person who you always look for the very best doctors. And you're going to go on the internet and find something that they don't know. And you're also going to be able to distinguish the charlatans from the real thing. Now, I think, often we'll say something true to a client and it doesn't penetrate. I think it's kind of luck. But on this day, it hit her and she's just like looked in shock. She's like, but then what is there? And I said, the odds. All we have are the odds. She came back the next week and said, all week I was wandering in a daze, just going, the odds, in a positive way. And she would tell you, she was late 30s, I think late 30s. I don't think she was 40 yet. Hopefully she won't be listening, so I won't get in trouble for that. But she would say that is, and this is about 3 years ago, she would say that is when she stopped being depressed. Because her whole life she could control everything, but always failed. And that is when she, in a really amazing way, gave up. And she had a lot of scary things happen. When she was having this dog who was dying, and I know that may not sound a lot to other people, but when she first came to treatment, she was unable to say the dog might die. But it was dying, and she talking about it in a way that would scare people. It's like, whoa, her dad is, beginning to get senile, and he's sick. And it was her sister came down with a cancer. It wasn't clear if her sister would survive or not.
Those
She
are
coped,
heavy doses of uncertainty.
and she coped with all of them. I mean, essentially, we did this just in time because her sister's ultra dear to her, and she depends on her sister a lot. And because of this, she was able to be there for her sister. Years before, she's like, I would have just fallen apart and couldn't handle it because I, wouldn't be able to say these things. So accepting that everything's just the odds freed her. Do you have a question?
Yeah. John, I wanted to throw this out there. I've heard from patients when we work on the concept of accepting uncertainty, and like you said, that we don't have any control and it's just the odds. I've heard from many patients who say, why do you have to think so negatively? Why can't there be some positive thinking? Why can't I have hope, right? And that I'm trying to focus on all of this negative stuff. What do you say to that if patients complain about that?
A few things, depending on which, I mean, they'll all come out at some point. I'd say the positive thing is that we're always trying to find a way to continue on no matter what happens. When we talk about the odds of something, well, I didn't say this is highly, and depending on what we're talking about, it's not necessarily highly likely.
Right.
But to say the odds are against it, it's very different than saying the odds are against it, so it won't happen.
Right.
And, there are many things when they are inevitable, coping is hard. If I lose a loved one, coping is hard. If I get a cancer and I die in 5 years, the issue is, do I want that to be the best 5 years it can be, or do I want to be absolutely miserable the whole time? And when I'm in denial and saying something can't happen, well, you've already proven to me that you can't be positive. And the reason you can't be positive is actually simple. You're saying under no circumstances is X allowed to happen. So if I'm afraid of having cancer, which is definitely something possible, right? I mean, I could get cancer, but if I'm afraid of it, yes, then I have to learn to cope with it the same way a person with cancer might cope. And in fact, a year ago, April, I maybe almost died, possibly. I was at the table with my kids, my daughter-in-law and my wife. And apparently during dinner, I keel over the table and are making weird choky noises, and they actually are pretty sure I'm about to die in front of them. I didn't find this out till much later. My son does mouth to mouth. I wake up, but I'm like laying on the table. They're like, "Are you okay? You okay?" And I'm like, I'm a little groggy. I don't feel like opening my eyes. I'm going like, "Guys, anything wrong? What's up?" And they're like, well, it took a while for them to realize I'm awake. Then they decide to test me, my cognitively all there. We took care of that like this. My wife goes, "What do you do for a living?" And I go, "I'm a hot shit OCD therapist." So my cognition was not in doubt. The medics get there. I'm rushed to the hospital, 2 days of testing. And I find out in the hospital that my son, he said, "Dad, I did mouth to mouth, on you." So at the end of this, two things. When I say to the docs, I know you can't tell me for sure, but my son doing mouth to mouth, do you think that was necessary? And they're like, "Well, because was this just, it looked bad, I was gonna be okay,
Yeah,
because all the results were good, so
right.
was it necessary or not? Like, can you give me your guess? I was just looking for
Yeah,
odds."
best
And the
guess.
answer was, "We don't know." So it's like, oh, okay, so I might have died, cool. And then they tell me I get the garbage diagnosis. And the garbage diagnosis is I have atypical syncope, which literally translates to you fainted and that whole not breathing thing's weird. But since you're giving your results, we don't think it'll happen again.
They
Now,
rubber stamped you.
and I know I don't have to ask, well, what if you're wrong? Because I know the answer. Well, if it happens again, you're in deep trouble because we don't know what's going on. We've just got the odds. Now I'm comfortable with that. But the person says like, well, I shouldn't worry about keeling over and dropping dead because that won't happen. Well, it probably won't. And and afterwards, like it's like, well, how about it happening again? Because let's face it, according to you guys, it shouldn't have happened once. So what happened this time?
Yeah.
Right?
And the answer is we don't know, and but we don't think we're not worried. I'm not worried, but so living with uncertainty, because for a lot, it's like I have to, I don't have a choice. Now, when we talk about if I can just shift, but it's related to trauma, because people often only treat half of trauma. So let me take, imagine a woman who's a rape victim. Everybody focuses on the horror of the rape and what she went through. And of course, that is necessary. But there's this other thing. All women know that they could be raped. And they treat it like a car crash, like, okay, it could happen. It'd be awful, but like, whatever. If you've been raped, you never get to go back to the world where it's not going to really happen. People are asking you, learn to be happy in a world where you can really be raped. And the idea like, oh, probably won't happen again. It's like, yeah, I'm sorry. It shouldn't have happened once. So we're helping her towards this acceptance. How do you learn to be happy in a world where this can happen again? That's overwhelming. And so for anybody who has any problem with uncertainty, it may not be as terrible as the death of your children or a trauma of a rape, but it's still something that feels unacceptably unimaginable. So why do we need to focus on the uncertainty and possibility? Because for that person, they're saying something else impossible. This can never happen. Like with social anxiety, we'll all say to the person with social anxiety that, hey, if you go into a room of 15 people, there might be 7 people who like you, there might be a few people who just don't care about you, and there might be 2 people who just hate you. It's probably inevitable. But if you demand that no one hate you, well, right? I can't do treatment. Treatments can't be like convincing you like, oh no, everybody's gonna like you. Or you don't know what they're really thinking, so they're gonna like you because probably somebody's gonna hate you. And it doesn't matter what you do. I remember one woman I worked with, she was a very quiet, what she felt a shy woman. And she was always kind of scared of everyone around her. She was a student. One day, everybody in her class explodes at her. And they accuse her of sitting up, kind of sitting up high, judging them and looking down at them. So here she is, she thinks this little shrinking wallflower that everybody thinks is a pathetic nothing. And the perception she's given off is that, as if she were high and mighty, judging them all. However I act, somebody's going to dislike it. I know when I give talks, I generally do well in talks, but I will always get some people who basically think I'm an arrogant jerk and, hate me. I know exactly what they're talking about, but it seems to be the exact thing that a whole bunch of other people are liking. So I have to, there's some things I need to accept, and one of them is low probability events happen. And I don't have to deal, the low probability, most people, unless it's their form of OCD, it's like, I ask them, do they want to be maimed, paralyzed, disfigured? To date, no one says yes. Thank God. How do you get around town? I drive. Okay, so you risk some idiot ramming you and doing that to you. Your brilliant plan is, I hope it doesn't happen, and I'm not dealing with it till I'm bleeding out, crushed under the metal.
Yeah.
That's what we're trying to do for all the other uncertainties, like to try to hope to cope when it happens, no matter how awful, because the bottom line is, if it happens, you need to. Some people might say, oh, if that happens, I'll commit suicide. And I say, well, for purposes of our treatment, you're condemned to life. Well, because saying I'll commit suicide is literally a way of, I don't want to think about what comes next.
Right?
Right.
Yeah,
I don't want to think about what comes next.
That's what I say.
Sorry. Yeah, you're going to have to live. Now tell me what's going to happen.
Now, okay,
Yep.
so you've tried to commit suicide and it doesn't work. Now what are you going to do?
Yeah.
Yeah, we prevented that. You said you're
That's
condemned to life. Now
Yeah.
what?
I love
How are
that.
you going to make the best of this?
It's true. And we're all in the same position, right? We all are.
Yes. I mean, I think the thing about, I tell my people with OCD that if you recover from OCD, you will not be normal. You'll be better than normal. because the average person doesn't really cope with uncertainty doesn't cope with uncertainty. I mean, better than you at this moment in time, but generally they get to use denial. And your OCD puts you in this position of heaven or hell.
Yeah.
Denial, you're not good at denial because you keep going, what if? So you've already tried hell. Let's try learning to cope.
Yeah. So you had mentioned social anxiety disorder. And one of the questions we had for you today was about the idea that OCD and anxiety and social anxiety disorder tend to run together. And we see them a lot in patients. I'm treating, I think, 3 patients right now who have OCD and social anxiety disorder / social phobia. And I'm wondering, how do you manage treating both disorders together?
It's a funny question because part of my answer is like, why is that a problem? I think there are the places where there are overlap and the places where there may not be overlap. Because I think for some people, their OCD and social anxiety are really maybe 2 problems, but they're sharing the same set of feared consequences. And that requires me to do something different than, okay, their OCD is contamination and they have social anxiety that doesn't seem contaminated by OCD things. And so that's going to moderate what I'm going to do for treatment, and there's the whole question of is there or is there not a lack of social skills and all the, potential social anxiety issues. But there is that point where there's going to be the commonality of, and this is probably patient dependent, right? Are they sure they're a social pariah? Which is different than they're afraid they're a social pariah.
That's a really good way right there to, I think,
distinguish.
Yeah, like that's a really good way to describe that.
Yeah.
Because you can get, I think a person maybe not specialized as much could make that mistake.
Yeah. And right, if they feel they're a social pariah after establishing that, they actually are not. Right, then I have all these issues of self-esteem to deal with, and there's some questions you can always ask. Do you guys know from your training what a Barnum statement is? This is like really old,
Are you like Barnum, like Circus, Barnum and Bailey?
Yeah.
Hey!
A Barnum statement is one that you can pretty much always say and it's going to be true.
Oh.
So as a therapist, you can look really good.
Yep.
So pretty much you hear somebody has self-esteem problem.
I'm taking notes, by the way.
Yeah. They have a self-esteem problem. Yeah, I have another question I wanted to ask along those lines, but it's off subject. But I'll get to it.
Okay.
You ask, so listen, are you the kind of person where if somebody gives you a compliment, you're going to either think they don't know you or they're just being nice? Right? This is a high probability yes. And then I'll say, okay, and so are you, by the way, I'm looking down because I'm trying to quickly pull up a prop. And
Another
then I'll
one?
say, well, I didn't have the other prop, but I got this one.
Yeah, that's right.
And then I'll say, and are you the kind of person where if somebody says something kind of negative, for the most part, you'll tend to believe it or worry about it? Which the answer is yes. And I'll say, have you ever heard of rose-colored glasses where everybody sees everything, nicely? Yes. Well, here's what you wear. Because think of what you've told me. There is no way for anybody to make you feel good. You were, anything good, you're discounting, and anything, so, and to think about your self-esteem. Like, you have social anxiety, you have anxiety problems. And this self-esteem problem is actually worse. Because the social anxiety problems or the OCD problems, you think that's crazy. You believe the self-esteem stuff. I talk about working on self-esteem. I'm talking about you have a messed up way of looking at yourself, and we're going to help you be more accurate. Somehow in your mind, it's like, oh, we're going to turn you into an acceptable human being. But I think you're already that. So working on the issues of self-esteem and self-compassion, because I think they're very closely related, right, becomes an entire additional issue that, you're going to be stuck working on with the people who are, in their mind, a social pariah. I still think there's probably a lot of uncertainty issues because they still worry about everything they do. They still worry about the effects of everything they do. They just have they shift the odds to a greater probability, and they all hate me. Who's the other person who's just worried they all hate them, and maybe they're a little positive in their guess as to whether people hate them or not. How do I cope with that? And the other great thing, I'm just going God because, oh no, the missing prop. They're my home office. A lot of times if you talk to anybody with social anxiety, you'd ask them, would they judge somebody wrong who did whatever it was they did? And generally they're pretty nice, and of course, the cognitive therapist in us always wants to go, double standard,
Yeah.
but if you've tried that, actually, but it never works.
No.
It's like, yeah, so I got a double standard, so what? Sometimes I will ask them to justify it in an essay, which they can't do, but that forces them a little bit more to think about it. But so we have this double standard going, and but they admit that they would not dump on somebody for that. And they will also admit that if you saw another individual dumping on somebody for this behavior, how would you feel about the person who's dumping on that person? And right there's anywhere from they wouldn't like that person to they might even defend the other party, because many of these people are way better at defending others. I said, okay, so what I'm understanding is the people you would like to be friends with wouldn't do this. And you're trying to please these people that you basically think are jerks. But, some people might think this about you. But given your feeling, I think we need to teach you the 5 magic words. Well said, Kate.
Do we need a drum roll?
No.
Okay.
And, and I think generally better is an in your head thought, but I don't want to make that judgment for people. And I like to be generous because, I don't know what other people are really thinking for sure. So I like to think to myself, if so-and-so is thinking this, and then the 5 magic words, they can go fuck themselves. Because that's a feeling they can get on board with. Now, I also have to point out, and I'm like 90% right on this. I try to emphasize, please remember this because everybody gets it wrong a week later. It is they can go fuck themselves because invariably, and I will tell them exactly what invariably they'll come back a week later and it's like, what are the 5 magic words? I don't give a fuck. I said, no, because you do care.
Yep.
Like I'm sorry, you do care, but being angry and pushing back, that you can do, and we'll have them repeat. Like, so what are the 5 magic words? I don't get, they don't give a, oh God, I'm getting it wrong. They can go fuck themselves.
They can go fuck
There we go.
Yeah.
So, and I'm dead serious with that. I mean, it's doing that with anybody, and they certainly laugh and everything. But I have people who really, have written down 5 magic words to make sure that they do that because, again, these are, they're allowing themselves to be judged for something they don't judge people for. You at least do something horrible enough that we agree is terrible.
Right. It reminds me a little of assertive defense of the self, kind of like turning all of that self-doubt into anger towards the other who might be, hurting
Exactly.
you.
Exactly.
Yeah.
I just, I just think sometimes drama is better than, a dry description.
Yeah.
And I think there are a lot of ways I state things that people just write off as to, like I'm kind of a crazed cowboy. But actually, many of them I'm doing on purpose because because it does interfere with the frame of the mental frame of the situation. You know, if I have somebody who has, you know, maybe I'm going to kill somebody and they have that's their OC fear. And I'll say, well, you know, I can't know for sure that I'm not going to slice and dice my wife tonight. So I say that, and people listening, professionals, it's like, you know, wow, well, I said that. But I'm saying slice and dice purposely.
Yeah.
I am on purpose saying something that first of all is a little bit humorous in a really dark way. If they have fear of kill, you know, if their fear is harm thoughts, it's like weird, but it's kind of funny. But I'm helping them put some distance there without like purposely like step back, you know, because at that moment I don't need to go into the ultra grisly, horrifying details of a serial killing and, you know, all the things that I can easily state. So I think I am so dead serious about they can go fuck themselves. And not saying it is they can go F themselves, you know, saying the word, because I actually think in this case, way more effective for breaking through what we're trying to break through.
Right. That makes such good sense.
Yeah, I love it when you're talking with somebody and they, like, for the first or second time, they're like, they let the F word slip. And they're like, fuck. And they're like, oh my God.
Mhm.
And I'm like, no. Fuck and shit are technical terms in this office. Please let them fly. These are
Right.
widely encouraged.
Yes.
So
And with
Probably
me,
gonna
the
have to
question,
edit that
and
out.
with me, I hope not, because, you know, I think it's clinically useful. And I think with me, the question is, do they even make it that far before I've said it first?
Yeah, that's true.
probably not, right?
The odds. Everything is the odds.
We can only play the
Yeah.
odds.
There we go.
So the last question I have is more of a summary question. And so I'm wondering if Zach, if you have any questions.
Well, yeah, I did, because when we were chit-chatting earlier, you made a interesting statement that has exactly to do with social anxiety, and you said you were very vulnerable with us, John, and I really appreciate that. And you said that when you speak, you get nervous. You have some kind of social anxiety with public speaking. Is that right?
Not quite,
Not quite.
but I will tell you the tale.
Would you please? Okay, great. Thank you.
In graduate school, my first year,
This is at Iowa.
University of Iowa, yes.
Okay. The reason I asked, I went there too, so we have that in
As a
common.
undergraduate or graduate.
Both. I went
Both.
to undergrad and grad. Yeah.
You know, because you know, the department we learned a lot, but they were very aversive. But that aside, I'm doing my first case conference. You know, it's like 2 months in. It's around it's just around a conference table. You know, there are somewhere between 6 to 10 people in the room. You know, so it's not a big deal. And I began my case conference like this. And after an inappropriate amount of silence, the first words that came out of my mouth were clearly spontaneously and not thought out, because what I said was, I won't panic. That was then followed by,
No.
and after that inappropriate silence, I proceeded to really read shakily the notes that I had, and it was really impressive. My speech anxiety was kind of interesting. I could raise my hand in class and talk, no problem, but put me in front of the class and it just fell apart. So I worked really hard during that next 4 years of graduate school at avoiding public speaking. Did a great job.
Were you on the all-star avoidance team?
Probably.
Yeah.
At least a close runner-up, right?
Yeah. And the other place that would get me, which would surprise people, is when if I was with a client who didn't have anything to say. Like I could respond, quickly, but if they didn't say anything, I'm sitting there going like, oh my God, what am I going to say? Do I know what I'm doing? I'd be thinking so much about that, I really wouldn't know what to say. It'd be a really awkward silence, and so that was fun.
And I'm supposed to be silent. I'm supposed to allow for the therapeutic silence, right?
Now that's strategic, but that's different. Unless, I'm a classic analyst, in which case I can get away with it because I'm just,
That's
whatever, however long you go, your problem, your money. So in my internship, pretty much almost all psychology interns want to work in a med school. I can teach, do clinical practice and research. I had that same goal, and I had the insight of my internship that, oh, wait, if you want to work in a med school, this means you're going to have to teach. Maybe you should do something about this speech anxiety. So I proceeded to volunteer to talk whenever I could, but I had to come up with a method. I can't memorize what I want to say because I know I will panic and block it out. I cannot write everything out because I know I will read it and screw it up. And this is before PowerPoint because I'm that old. So I came up with a method. I would write out the whole talk. I would then redact it. I would then cross out so I only had small phrases on each page, which were enough to keep me from getting lost, but not enough to have me read it. And I would practice the hell out of it. I practiced my jokes. I would just practice it till I could do that smoothly. And one thing I did that I would recommend for anybody actually public talking, I would do it out loud so I could hear myself. I only knew it would come out if I could hear it. So that worked. I also went in and I would always ask a friend how I did with the knowledge I'm not going to believe them. Right? I'm going to do this. I'm not, I don't know if I did well or not, but I'm just going to ask them anyway. And they said I did well. I'll give it some account, even though I know it's not going to feel true. Anyway, so that's what I did that worked, till I, so I'm not scared now. I think the next major challenge, my friend Charlie Mansueto, we used to walk around at conferences at 2 a.m. talking psychology, being drunk. Charlie said, hey, you know what? We should do this on stage. Like just have a random talk about, OCD. And I'm thinking, wow, this will screw me up because I won't, I can't have notes. And at that time, I thought I said yes. And I literally thought to myself, I have a pretty good rep going in here. This could look really bad. I'm going to do it anyway. It wasn't like, I know this will work. It's like, okay, let's just try it. And we thought nobody would come. We were wrong. It was really packed. And so Charlie and I, for the next 8 years, did that every year. We would pick a topic. And, it was one year we picked a topic and both of us said, I don't know much about this. I don't know either. And we wanted an hour. They gave us an hour and a half. And a half hour in, I know we've shot everything we know. I just know, I know I've said it all, and I know Charlie said it all. We went on for the whole hour and a half and ran over. So anyway, so I did have that. I don't get the speech anxiety now. So I feel like I'm a good poster child for, overcoming speech anxiety.
Absolutely.
The fear was really very simple. I'm going to panic, screw it up, and look like an idiot because that's the way I started. And I did look really, really nervous when I would talk, and during graduate school when I, didn't successfully avoid. So exposure worked, and so that answers your question.
Yes.
Yeah.
It does. Zach,
Thanks for sharing. Because honestly,
very exciting.
Katie and I both know you. We've had several interactions with you. So I never would have guessed that about you, honestly.
Yeah.
So thanks for sharing.
Humble beginnings, right?
Yeah, there you go.
Or not so humble with Endofoa. But Zach, if you don't have any other questions, I'm gonna slightly modify what I was gonna say for our summative question. And part of it is because of something that John, that you brought up earlier. I wanted to tap into the statement you made about how poor therapist training is in the treatment of OCD and anxiety disorders, and how it's so surprising that given the wealth of information that we have out there, that therapists remain poorly trained, and end up oftentimes making patients much worse than they were to begin with, because they end up providing them with reassurance or encouraging avoidance behaviors, encouraging parents to provide reassurance, etc. And so I think what I'd want to know is, what are your thoughts on our future and how we're going to remedy this big problem that we have, and getting everybody on the same page in providing what is the gold standard?
So you really want to do the impossible.
Is it really?
Well, partially. I mean, again, both APAs, virtually every expert, OC Foundation agree, and we're still minority. Just CBT as a generally empirical approach, we're still not a majority. And that's why we're looking at the people who do all that stuff badly.
Yeah.
So, I mean, I think it's a gradual process that does get better. I mean, I think this may shock you, but before 1999, intolerant uncertainty was not seen as the core problem of OCD. In fact, that special is a cognition something working group. They specifically discounted that as a major factor when they're thinking of the cognitive distortions of OCD. So in a positive way, wow, that has changed. You know, it's pretty widely accepted now that that is the core problem. So there is progress, and I think, you know, like a virus, we spread slowly. So I think you know, there is that. I think one, you know, so I think education is just painfully slow. I think it's kind of moving in a positive direction. You know, I think the other direction that we move in has to do with good research versus GIGO research, GIGO. GIGO is a term from computer science, meaning garbage in, garbage out.
Yeah.
Because there is that, you know, so like when ACT first came out, there were studies where they were comparing ACT to ERP. I think those are GIGO studies because, first of all, in those studies, nobody was doing ERP in such a pure way, and nobody was doing ACT in that way. I do think there were some ACT practitioners that suffered because they didn't know how to treat OCD. So I really think the issue was, well, and the issue and the focus of research is not like ACT versus ERP. It's like, what is the best way to incorporate this for the treatment of OCD? How do we work it so that we are modifying this procedure for the problems of OCD versus trying to modify patients to fit into a model, you know, that it may not. You know, the same way that cognitive therapy initially applied to OCD, a model for depression, it was just kind of trying to treat it like depression as opposed to, so it was never an issue that CT is wrong. It was people doing CT and ignoring all the principles of CT in their treatment of OCD. So I think trying to always keep in this thing that people give lip service to and ignore, which is like, we start with the clients and what are their problems, and you know, how do we do that? So I like research that if there's some new procedure, you know, there is the question, does it have anything to offer? I mean, with ACT, you know, some of the early arguments that anti-ACT people are going like, well, I'm already doing that. It's like, yes, we are already doing that, but this is a way more organized way. So there's probably something here we can use from it. You know, but what is the best way to incorporate it? You know, and that's an empirical question. And, you know, one that I think Hayes would endorse because he's an empirical person. You know, it's like not do it or don't. It's like, what is the best way? So I think keeping in mind what is the best way to incorporate new procedures, you know, if they make sense. I mean, you know, certainly plenty of garbage procedures come along, and you know, that's always sad. If something becomes popular, I kind of hang my head down and go like, okay, here's 5 years down the drain. But that's an acceptance issue.
Yeah, that's true.
Yeah.
Well, it's just been so exciting talking to you today, John. It
Thank
was
you.
wonderful. Zach, do you have any other questions or thoughts?
Oh, probably about 1 million, but that's not going to work out. So that's an acceptance issue.
It's been a pleasure.
Thank you so much,
Yeah.
John, for your time.
No
And
problem.
on behalf of the National Social Anxiety Center, thank you so much for doing this interview with us. Really appreciate it.
Thank you so much.
All right, take care.
Bye-bye.